But just to begin, why are we talking about this in this meeting? Because things changed during the last few years, and at the moment, more than AIDS-related conditions, and we have other problems, namely death related with liver disease. And as you can see in the DNA study, in the more than 23,000 HIV persons, namely 14% related with the deaths were related with liver, and HCV was responsible in 10%, B in 2%, so this is a very important issue. Just to show you a work that we made in our co-infection group in Portugal when we compared 5 years and another recent 5 years, and as you can see, when we see the causes of death in Portugal, opportunistic infection, non-opportunistic neoplasms, non-related neoplasms, and liver disease, you can see here then it increases from 9% to 18% during this year. So it's more or less the same problem we have. So talking about these two viruses, we know that both can lead to chronic disease, both can cause cancer and death, but neither can be eradicated. So we know that in the ARA-IRT, things change, and as I told before, at this moment, liver disease is the most common non-AIDS-related cause of death in about 14% of all of these patients, and in almost half of deaths among hospitalized HIV-infected patients. So we have to do something. And reasons why liver disease are one of the most important causes of that, because if these patients have naturally, because of these viruses share routes of transmission, it's not surprising that HIV population have high prevalence of other viruses, namely B and C, because there is an hepatotoxicity of heart drugs, and not only heart drugs, because these patients take other medication for other reasons. And not forget, maybe we can call this new emerging liver disease that were already mentioned yesterday by Patrick. So what is the role, the real role of hepatitis B in HIV and vice versa? What are the interactions between these viruses and the role of antiretroviral therapy? Well, begin to the hepatitis B. This is a real problem all over the world, because we know at this moment maybe there are about 400 million infected people. Of course, it depends on the geographic area. We know that sub-Saharan Africa and Asia are areas of the globe with very, very high prevalences of hepatitis B. Regarding the co-infection, if there are so many HIV populations, so many HPV-infected persons, there is an overlapping population. So we estimated that 4 to 8 million people are infected with both viruses. We talk about liver mortality globally. What's about liver mortality related to HPV? This is not a very recent study. It was published 10 years ago by Theo in Lancet. It's a very, very well-known study, the MAX study. And when evaluated HIV people with hepatitis B, you can look that liver-related mortality is 18 times higher in co-infected versus hepatitis B alone. So, which is the real prevalence of co-infection? We estimate that this co-infection exists in more or less 10%, depending, of course, as I said, in the areas. There are areas, endemic areas, why these prevalence are higher, as I mentioned, Africa and Asia. And of course, these prevalence are also different regarding the group risk. I mean, this prevalence is higher in intravenous drug users and in homosexual men, and a little lower, for example, in heterosexual. What's the real impact? This has been along these years very controversial. What is the impact of HIV over HPV, the HPV over HIV? So let's look at what's the impact, the real impact of HIV on the natural history of HPV. Of course, if a patient is very depressed, immunodepressed, there's no control over HPV. We understand that. So it's an impairment of the innate and adaptive response to the virus, to the B virus. So what are the consequences? Higher serum levels of HPV DNA, lower rates of loss of these antigens, the E and the S antigens, less seroconversions, so an increased risk of chronicity. You know that usually in monoinfection, B monoinfection, the rate of chronicity is about 5%. In these co-infected patients is higher than 20%. There's an increased risk of reactivation in this population, mainly in active carriers. There's a faster progression of fibrosis, so an increased risk of cirrhosis and hepatocellular carcinoma, even in lower ages. So there is an increased liver mortality. But we think, since recent years, that these things are going to change. Why? Because we know that heart therapy at this moment, and according to not only the recent guidelines, but also before, when we have a co-infected HPV-HIV patient, we have to treat both infections, as we have the opportunity to have drugs that have a dual activity. So when we begin to start to treat these patients with heart with a dual activity, maybe the things are going to change in the near futures, and we expected in the future that maybe the prevalence of liver disease associated with HIV, HPV is going to be lower. So, and curiously, this paper just reflects what I said. It was published 3 years ago. It was performed in France, and the M was compared co-infected patients versus B HIV negative. It was a multi-center study, and the conclusion was that in HIV, in a multivariate analysis, shows that older age, low initial levels of DNA, longer time of beat therapy significantly correlate with undetectable levels of DNA. And curiously, when they analyzed the clinical presentation and the liver fibrosis score, they didn't find differences between HIV and HIV positive or HIV negative population. So it seems that if we treat these patients earlier, maybe the big problem that is the progression of fibrosis, it's lower. So let's see what's going to happen in the future. So maybe we know that heart is going to reconstitute, at least partially, the specific CD4 and CD8 responses. So there will be certainly an increase of improve of the HPV serological outcome. Well, but the question is, there's another very, very controversial issue, is the influence of hepatitis B over HIV, because it was speculated many years ago that maybe, for example, these co-infected patients have a higher susceptibility to have liver toxicity, for example, or to have a lower reconstitution. So let's see, for example, a very recent paper published this year. What is the real impact of hepatitis B over HIV? And the conclusion is on the title. Hepatitis B virus co-infection negatively impacts the HIV outcomes. And if you see, this analysis was made in more than 2,000 HIV recent seroconverters, in which 20% as a resolved infection, 3-4% as an isolated HBC antibody, and 2-7% as a chronic hepatitis B. And the conclusion of this very recent paper was that risk of clinical AIDS and death was significantly higher in chronic hepatitis B group compared to HPV negative. So the role of hepatitis B is very important, at least in the evolution of fibrosis. So we can conclude that we should treat these patients very early, as we would see. Regarding another important question is the occult B infection, because this has been analyzed for many years, not in HIV, of course, before the HIV was known. And what about the HIV population? First of all, the definition of this entity is the presence of the DNA in the absence of this antigen. So there's no HBs antigen, and it's a replication of the virus. Sometimes the only marker in the blood is this one. So it's very common in HIV population that the only isolated serological markers is anti-HBC. So what does this mean? Maybe it could reflect the phase of HPV infection between inactive disease and reactivation, maybe result of immune depletion and lower CD4 cell count in the case of HIV infection. Well, there are different prevalence of occult B infection in HIV, and maybe we don't know the real impact of it. And for example, one of the reasons could be, for example, the different cutoffs of the different assays. But what's the real magnitude in recent publications of this entity and then the clinical impact of it? As Karina mentioned yesterday, of course, if there is areas of the globe that the prevalence is higher, it is expected that the occult infection is also higher. And as we can see here, occult infection in sub-Saharan Africa represents about 10% with very high levels of DNA. This population has more than 2 logs in medium. In case of Asia, about 9% of occult infection. But for example, if you look to Europe, this is a very low prevalence of occult infection. We can say that in this situation, usually viremia is low and intermittent. But we couldn't expect that it makes any injury to the liver. And really, this entity could constitute a risk factor for unexplained cirrhosis, for B reactivation, when it can occur, under chemotherapy, under biological treatments like rituximab, after discontinuation of therapy. There are 2 recent papers that are referenced here, very interesting. One of those has already become a seroconverter with HBs antibody, but after discontinuation of therapy, it has been a reappearance of the HBs antigen. So this is called a reverse or a seroreversion. So in HIV population, we don't know yet the real clinical impact because, for example, in the co-infection with HCV, HBV occult or B occult plus C virus, we know that the progression of fibrosis and the risk of carcinoma is high, but we don't know yet what it represents in HIV setting. At the first approach to a patient like this, how can we assess liver fibrosis? We can evaluate fibrosis through liver biopsy. It's the gold standard, of course, as you know, because it allows us not only to check fibrosis, but also the necroinflammatory activity, as also to provide information about any comorbidity that could alter the prognosis or the treatment. And there are other non-invasive markers, the FibroScan and biochemical markers. Just to mention you this study that was published last year, when these authors treat or at least analyze only co-infected HIV and HBV patients, compared liver biopsy with FibroScan. And as you can see here, some results. We know, for example, in HCV that usually we consider an F4 or a cirrhosis when the kilopascals were up than 14. But you can see here that the levels in B infection are a little lower. So the cutoff is a little bit different in B infection compared to C infection. But for example, if you look to the negative predictive value in F3, F4, it's very good. So it seems that there is a very good correlation. And the conclusion was that a significant correlation was observed between liver stiffness measurement and metavir fibrosis. And another conclusion is that with this algorithm that combine the FibroScan and the biomarker that I'm talking later, 97% of patients were well classified. So it seems that combining FibroScan with another serum marker, it could be a good idea to avoid liver biopsy in any situation that is not possible to do it. Regarding the biochemical markers, just to mention this, this is a very important paper published in this year, and Karine, I advise you to read this paper that she published recently in Gut, when these authors combine about 11 biochemical markers, because it's a very controversial item. I heard, for example, very recently an Italian colleague talk about FIB4 that is very, very important in HIV population. But in fact, these authors find out that 3 of these biochemical, namely FibroTest, Fibrometer, and EpiScore, have proven to be accurately associated with levels of liver fibrosis. So maybe we can have the right biochemical markers in HIV population. What about treatment? I think I give you the idea that we have to stop very rapidly the progression of this disease. So to halt the liver disease damage, treatment is a priority in co-infection HIV, HBV patients. And just to reinforce this publication, very important publication, that was because it was a meta-analysis that includes more than 12,000 patients, HIV or co-infected. The conclusion was there was an increased risk of 36% of dying of all causes if the patient was B positive compared to B negative. So what the guidelines say? The guidelines say at this moment that we should treat these patients early. And as you can see, there are 2 situations for B infection. The hepatitis B has to be treated or not yet. But if this entity should be treated, we should treat early, independently of the level of CD4. Even if a patient has more than 500, it's recommended to treat HBV and HIV at the same time. In this situation the B treatment is not required yet, we could eventually defer treatment if the CD4 levels is up to 500. Of course, in hepatitis B, these are the drugs that were approved for many years until now: interferon, lamivudine, adefovir, entecavir, pegylated, talbivudine, tenofovir, and etricitabine. In the co-infected population, or the only situation that it's like, let's see, because for example, etricitabine, it's not approved in monoinfection. Truvada, the combination tenofovir plus etricitabine, it's not approved. But let's see if in the co-infection we can use these drugs alone. Let's see. Maybe talbivudine, at least I don't know if anyone has access, because in my country, no, and I don't think it's a very good drug because it has a cross-resistance with lamivudine. It can also cause renal dysfunction. I don't know if it comes. Regarding some characteristics of these agents, just to see at least these very important points. Regarding efficacy, we can see that just look, for example, if you look to the guidelines, the very recent guidelines published in March this year regarding hepatitis B monoinfection, there are only 3 drugs that are in first line. It's entecavir, tenofovir, and pegylated. And as you can see here, the efficacy is similar. When we look to resistance, we can see that PEG has no resistance. Tenofovir has no resistance, at least the studies after 6 years in monoinfected people, there's no resistance identified. And entecavir, yes, a little bit more, because after 6 years there's 1.2 risk of resistance, but this resistance occurs in the first 3 years, no more resistance after that. So, but as I was mentioned, in a co-infection, what's happened? Let's see, for example, the experience with entecavir in monotherapy, without HAART, without antiretroviral therapy. McCohen in this paper in CROI in 2007 shows this. When it treats a co-infected patient with entecavir without HAART, what happened? In 3 cases, a drop of the HIV RNA was reported. And more seriously, the mutation 184 appears. So maybe there's an influence of the entecavir over HIV, so it's not a very good idea. Another paper later on, 1 year later, in 17 co-infected patients under monotherapy with entecavir, the conclusions or the findings were similar. It means that it happens a significant reduction in HIV RNA in a majority of patients and the selection of this mutation. So HIV, HBV co-infected individuals should never not receive entecavir in monotherapy. It could be used, combined with it HAART, but never in monotherapy. Regarding talbivudine, there was a paper I remember in a workshop of co-infection 4 to 5 years ago that they find the same. Talbivudine in one case caused a drop in the HIV RNA. So at this moment, it's not very conclusive if this is a good idea to use alone in co-infected. So what say the guidelines? The guidelines say that, for example, regarding the HBV, if the HBs antigen positive, let's see first. If you have a B patient, let's look for degree of fibrosis. All the patients that are cirrhotic should be treated. Even in the monoinfection B is the same. We don't expect it that the patient could have DNA levels. It doesn't matter. If he has a cirrhosis, he should be treated. And even in patients with F2, F3, independently of the DNA or the level of ALT, they recommend to treat, because we know that these patients have a faster progression of fibrosis. So, as I was said, in these positive patients, if they have cirrhosis, they have to be treated. And if they don't have cirrhosis, let's check for the DNA. If the DNA is more than 2,000, we have to treat them. If they have lower level than 2,000, let's check for ALT. If they are elevated, we should treat. If they are normal, we can just monitor. So looking for this the liver biopsy maybe is not so important in spite of it's a very good tool to appreciate other things, as I mentioned. So in concluding this in this chart regarding the therapy, let's imagine that we have a co-infected HIV/HBV patients, and of course, if the CD4 level are less than 500, or it is a symptomatic HIV patient, or it has cirrhosis, we should treat. Okay. And we should treat how? Independently of being a previously experienced with lamivudine or not, we should always include in the scheme tenofovir plus a TC drug. What is a TC drug? 3TC or FTC, lamivudine or intricitabine. So the scheme would be in an HIV patient should include always tenofovir plus intricitabine or tenofovir plus lamivudine plus another drug. And the question is, more delicate question, if the patient has a CD4 level more than 500. So maybe this patient has no indication for HIV, but what do we do? So we have to check if the treatment for B is required. If it's not required, we can wait. But if the B treatment is required, we have two options. Imagine that the patient said, I don't have criteria for HIV treatment. I don't want heart because of the secondary effects, because of my daily journey. I don't want to take heart yet. So the only solution is pegylated interferon. But the question is that pegylated interferon has been successful in certain cases, like individuals with genotype A or B, individuals with low level of viremia, namely less than 6 logs, in patients with ALT elevated at least 3-4 times of the normal. If you check your patients, usually do your co-infected patients have low level of B viremia? No. So maybe there are very, very few candidates to pegylated interferon. So the other solution is to begin heart early, and heart should include, again, tenofovir plus 3TC or tenofovir plus FTC and the third drug. But this is a very provocative question. So if the patient is under therapy with Truvada plus another drug, and even so, at the end of 2 years, for example, he continued to have a detectable B viremia, what to do in these patients that are not completely suppressed? Well, I can show you 2 recent studies published last year that the intention was to intensify therapy, just to find out if those patients under tenofovir that should be theoretical, they should be suppressed, in spite of we know that about 10% of these patients never, or at least during the follow-up of the studies could be not suppressed in 80 to 10% of the cases. What these authors try to intensify the therapy, the heart therapy with entecavir. This small study includes 13 patients E positive with previous experience to lamivudine, intricitabine, and tenofovir, and they tried to join Truvada plus entecavir. So they intensify the therapy, the scheme, the heart scheme, plus entecavir during a median of 74 weeks. And the results were that 38% of these patients achieved undetectable B levels. It's not too much, but this author conclude that maybe in patients failing to suppress HBV viral load on Truvada after 12 months, the addition of entecavir is not an unreasonable, particularly those that have a higher risk of progression of the disease and and higher risk of decompensation of the hepatic liver disease. Another small study in only 10 patients with previous experience with tenofovir or 3TC/FTC during 48 weeks, they do this. In half of the patient, I mean in 5 patients, they intensify therapy. They put entecavir plus heart. And in remaining 5 patients, they did nothing. And they found that among these 10 patients, 5 have no drug B resistance, previous resistance, and in 2 subjects there was this very important mutation to 3TC, the 204. They intensified with entecavir 1 milligram in 5 patients, or they keep the heart as they were in the remaining 5 patients. Just to remind you that the recommendation for the use of entecavir is 0.5 milligrams a day in a naive patient, but if one patient has previous experience with lamivudine, we should all the time always give 1 milligram. And the conclusion of this study was that in those patients that were intensified, all of them become undetectable after 48 weeks. But curiously, 2 of them that has no entecavir become also negative. So it could raise questions. So should we intensify therapy? Do we know what will be the correct time to intensify if we need? Maybe these patients will be suppressed after 3 years, 4 years, but nothing happened until there. We don't know. So the conclusions about the intensification was that it remains unclear that intensification is indicated to treat persistent viremia despite tenofovir therapy. But it could be irrational. And the rationale for intensification, it could be for 2 reasons. Prevent drug resistance, because as we know in HIV, we should never keep patients with detectable viremias. And in spite of at this moment, there are no resistance to tenofovir identified. We don't know if it is going to happen after 4 years of therapy. I just remind that it was really isolated a mutation in tenofovir. It is the 194 mutation, but at the moment, we don't know yet if it has really a clinical impact. Maybe not. And the other reason is to reduce the adverse outcomes associated with the viremia. So if the viremia persists positive, something goes wrong. And we can't forget the REVEAL study that was published, I suppose, presented in 2006 by Chen, that correlated the DNA levels with the risk of carcinoma. And I remember 1 year later, after this presentation in Aisley in Milan, I remember perfectly that it shows the same result. Even patients with 300 units copy of DNA could have the risk of carcinoma. So we don't know yet if we left the HBV patients with viremia positive, at least in low levels, if it doesn't constitute a risk of carcinoma. How to monitor these patients, and just a brief talk about the role of quantification of the HBs antigen and S and E. We should monitor these patients at the beginning very closely, as we do for HIV. If we do perform an RNA for HIV, we should also perform a DNA for HBV. And of course, when the patient is suppressed, we can do these tests more separate, of course. And we should not forget that if we have a previous suppressed patient and he becomes detectable again for DNA, we should perform a resistant test, because that's the right moment to optimize therapy if it is appropriated. In every cirrhotic HBV patients, we should perform, as it was mentioned yesterday, we should perform an ultrasound and an alpha fetoprotein every 6 months, and also an upper gastrointestinal endoscopy. And what is the real role of these markers? This is not well known, but this is, again, a publication where Skarin is a co-author, published this year. And they want just to analyze, there is a score for HBV monoinfection published by Brunetto, but in co-infection we don't know if it is the same. So in these co-infected patients, the authors try to evaluate if the evolution, the decline of these markers could be correlated with the efficacy of treatment with tenofovir. And they try to quantificate the HBs antigen and the HBA antigen in this population after a median follow-up of 30 months. And the conclusions were there were a very slow decline in HBs antigen. There was a 4% of loss of this antigen, but these patients where the loss occurred, 75 as a baseline level, very, very low. Regarding the HBe antigen loss, it shows a biphasic decline. So it seems that it declines first and later on. And in patients with CD40 count less than 3,500, decline of this antigen S and A were lower. So we have to wait for more studies just to have an idea if this could be a real marker. Anyway, it seems that the HBe quantification, maybe it's better than the HBs quantification. If we are treating a co-infected patient and hepatic flares occur, I mean elevated of transaminases with apparent no reason, what could be the causes? We have to keep in mind that if we have a co-infected patient under hard therapy that has dual activity against both viruses, and we assist to an elevated transaminases, we couldn't forget to check for the presence of eventually other virus, an acute virus. We should not forget that it could be a reactivation. In spite of we have a patient with tenofovir, a very potent drug, the probability is very low to occur a recurrence in this situation. We can check for toxicity of liver of any drug. We cannot forget the immune restoration that could happen in B co-infected if the increase of CD4 is very, very fast. We cannot forget this situation, the seroconversion, because I have seen this in monoinfected B patients. Usually a B patient is under treatment and suddenly the transaminases rise and, let's see, and sometimes the seroconversion is going to occur. I mean, loss of antigen E and appearance of E antibody. And another situation is the seroreversion, as I mentioned. So discontinuation of therapy in these patients is very, very dangerous because it could happen a new reactivation of the virus. And finally, viral resistance that we have to check. Of course, just to mention this, there are factors that could affect HBV resistance. Against the high efficacy of these drugs and the high genetic barrier. But again, for that, we could think that these patients have a very high replication. The polymerase that exists lacks a little to repair the errors, so the mutations can occur easily. And there's a very good ability of this virus to make compensatory mutations and to improve fitness. Other co-infections, very briefly, just to show this, if an HIV patient has one co-infection, two co-infections, or three co-infections, it's not surprising to see that the mortality is higher when the numbers of co-infections occurs. When we see the impact of multiple co-infections, we can see that it's not surprising because they have, most of them, similar rates of transmission. So in 30% of the HBV co-infected patients, they are also infected with C, according to Eurocida, and 14% of the HBV co-infected patients are also infected with D. So it's not surprising that these patients co-infected with multiple co-infections have a higher risk of significant fibrosis and cirrhosis and a more rapid progression to end-stage liver disease. This is a very well-known study from Castellaris. If we look for these columns, we see, for example, the representation of cirrhosis in C patients, in B patients, in only in HIV population, in both C and B infection, and B and Delta. Look, almost 70% of risk of prevalence of cirrhosis with the presence of B and Delta. That it seems that Delta is really the most dangerous virus. We know that the prevalence of Delta virus in co-infection are very different, but we know that maybe up to 5 to 6 carriers of the HBs antigen are also positive to DNA. A publication made by Soriano shows a percentage more or less of 10%. I mean, 10% of co-infected B patients has also RNA for Delta virus. What about E? The first reports that emerged in 1994 it seems that this infection was more prevalent in HIV, as you can see here, for example, in Russia and Belarus, 11% versus less than 2% in general population. And this question arises, are HIV individuals at a high risk of hepatitis E? So many studies were performed, and the prevalence range from 0 to 11%. This is some examples. In Germany, 5%, in Swiss, 2.6%, in France, 2.3%, and in Spain, 0%. In spite of the evaluation was made only in 93 HIV patients. These were some of the reports that I find in the literature very recently. This was the first in New England Journal from Dalton in a case HIV individual with cirrhosis. It was a very depressed individual, and they find out that the cause of this cirrhosis was the hepatitis E. And other published data was here. In all the patients, they have a lower level of CD4 cell count. So maybe HIV individuals have no higher risk of acquiring hepatitis E, but they have a significant higher risk of chronic evolution. This is the difference. And maybe in those with low level of CD4 cell count, seroconversion could be delayed or never occurred. That's the reason why the RNA could persist and leads to chronic infection and cirrhosis. So just to finish, what attitudes should we have when we have a co-infected in front of us? What attitudes, what should we do? And according to the guidelines, all HIV populations should be screened for other viruses such A, B, and C at the moment of diagnosis. If they are negative, we could perform an annual serology if appropriate. All anti-HBC positive individuals with no other markers should be tested for NTS, NT, and DNA, looking for an occult infection. Those without any marker or an occult infection should be offered a vaccination against hepatitis B. But look, that we know that the response to vaccination is completely different according to the level of CD4 count. So if the patient is very depressed, it's better to start hard first, and then when the CD4 count is higher, then vaccinate because the response is higher. We should measure, of course, usually after 1 month, we should check for the anti-HBs just to look if the patient get at least 10 units, that is the value that we consider to be protective. If this patient don't achieve this level, we should at least revaccinate, give a complete course of vaccination. The recommendation varies. We can have a double injection each time, or we can give not 3 times, but 4 times. So a double injection 4 times. If this patient, after a second course of vaccination, didn't achieve a protective level of HBs, so we shouldn't repeat it again. We should monitor this patient and eventually perform a serological test annually. So, consider the effects of co-infection, as HIV co-infection leads to an increased liver fibrosis and cirrhosis. Since co-infected is associated with a high liver mortality, since we know that B levels could be present even without any serological marker, since aminotransferase levels may be normal, even in the presence of significant fibrosis, has hepatic flares may due to several reasons, as I mentioned. What should we do? And I would like you to take some messages. We should prevent, we should vaccinate all the negative individuals. We should, in negative patients, in case of no response to vaccine, we should screen regularly these individuals. Even if they are under therapy, we should check regular for the DNA. We should introduce early the antiretroviral therapy according to guidelines and optimize the treatment in any case if appropriate, and never, please never stop HBV drugs if you have for any reason to discontinue our therapy. We should maintain at least 1 drug with B activity. Thank you.